have the stimulants and we have non-stimulants, and really compared to the last review, what's new is that now there is an FDA-approved alpha agonist. There is guanfacine, and then the rest kind of looks the same. So currently the guidelines say for level 1 and 2 stimulant monotherapy, and it says either methylphenidate or amphetamine, short or long acting. So it's like wide open for the choosing, and you'd be practicing consistent with the guidelines, you know, if you pick any of those. And if we just look at the effect sizes of stimulants for ADHD, and this is courtesy of a nice review by Dr. Farone, we basically see large effect sizes, some variation, but all of them are really large. So we wouldn't really be guided by considerations about effect size, but then we can be guided by thinking about need for timing of the medication effect, the dosing options, because wanting to practice fiscally responsive, you don't want to give them 2 pills if you can get away with finding the 1 pill that's the right amount, because the price of poker doubles, if you get into the 2 pills, 3 pills, 4 pills type of a dosing regimen. Concerns about would there be drug abuse or misuse, patient and family preferences. And I think we're now in this amazing point in time where we have all these nice long-acting medications, but you can get the short-acting ones for $4 at Walmart, and that becomes a reality where you really have to start thinking about this, and we might need to even have some more guidance on that in the future. Previous use experiences, I think the only thing that seems clear is that the transdermal methylphenidate is not recommended as a first choice here because of concerns that there could be allergy developments. So what might be some of the things we consider? We have the long-acting Ritalin that is available in 4 dosage strengths here, and it basically emulates a BID dosing, has the 50-50 distribution of immediate release and extended release. So that's one option. We have Metadate, and notice here we have lots of dosing options. So that's from the 1 pill a day perspective, that can be a good consideration. You have again a biphasic release, and the difference here being that 30% is the immediate release and 70% is the extended release. And we have of course, the old standby, the Concerta, only comes in 4 strengths, and probably most of you discover that those 4 strengths don't necessarily cover. You may end up with this double pills situation, but it is the one that emulates a 3 times a day dosing schedule. And the transdermal delivery system, which is available in the 4th strength here, and has a very nice feature of a long action time, and the fact that you can remove the patch if a situation develops where you don't need that long action. But then, of course, you have to cope with the potential skin side effects, and you have to manage that. So that's great. For the amphetamines, Adderall XR, also quite responsive in terms of available dosages, and just beautifully emulates a twice-a-day dosing of regular Adderall with a 50-50 distribution. And then Vyvanse, which seems to have become incredibly popular, especially with primary care providers. It seems like go to Vyvanse at the first blink, and they are also offering the wide range of dosage strengths. And we have the interesting scenario, a nice long half-life, and no no documented interaction with meals. Whereas with the other extended release medications, if you have children that eat the high-fat breakfast or the children that are on antacids, you start messing with the delivery system because they're not little clocks that travel through their body. They're pH responsive, so you might, with the other medications, have impacts of food intake, and we certainly have a number of kids on antacids, so that's not a concern here with the Vyvanse. So I think I just wanted to have that for us as a reminder. We have really excellent choices, and what we choose, I think we want to make it fit the child's need, the family's preferences, and lots to go by. So this level 1, level 2 recommendations, we seem to be in good shape here. The next level, the level 3, was atomoxetine and Strattera, our selective noradrenergic reuptake inhibitor. And probably everyone really familiar with Strattera at this point. It's interesting to keep in mind that they actually do have a maintenance treatment indication for up to 3 years. That is unique. So if you have somebody who is a atomoxetine responder, having some evidence that seems to point at this working for this length of time, I think that is that's something potentially of value here. We know that when we're working with Strattera, we're looking at weight-based dosing. We have instructions there not to exceed 100 milligrams a day, and probably also everyone from clinical experience kind of knows this, and from reading the literature knows this, that in these head-to-head comparison studies, we see a statistical superiority of the stimulants over atomoxetine. And now here is to keep our eye on the goal, because I think we need to just think about that a little bit. It's put on level 3 in the guidelines, and where I think this we need to give it some discussion time today is that we really are getting some clear signals that for treatment-naive patients, the response rates to atomoxetine are different than when you're working with previously treated populations. So in my mind, the point here is, if we declare that atomoxetine happens down the line, we're basically already potentially making sure that the chances are not as good. So I would like to save that for some further discussion. So because of the weight-based dosing, you want to have a lot of pill sizes, and there are. I don't even try and memorize these anymore, so this type of a thing I think can be useful to have. But even with that many pill choices, still you might end up needing to combine, and then it gets expensive really quickly. In the comparative studies, the meta-analyses like Steve Farron's meta-analysis shows a lower effect size for the atomoxetine than for the stimulants. And in recent US studies, we also see lower response rates. There may be some methodological points where you could say, maybe it wasn't given its full chance, like the study was too short and it may take longer to really see it, or the dosage wasn't really pushed high enough. But I think we also need to keep in mind this previously treated scenario, because when you look at a recent international study, they actually had comparable effects with stimulants and atomoxetine, and that may partially be a reflection that when you do a clinical trial there, you're just going to get more treatment-naive patients into it. And I'll show you a little bit more here what Newcorn's study showed in terms of preferential responders to methylphenidate and atomoxetine. And this is from the article that I had recommended as a seminal article for reading. It's in your binder. This is a really wonderful review article by May and Kratowski.